So good morning, everyone. Thank you for your Friday flexibility. We are so excited to invite you to a special Grand Rounds this month where we get to celebrate the work of our fellows this year and learn about the projects they've been working on. And before we get started, we'll just go over our land acknowledgement as well as some celebrations for this month. We acknowledge that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. This acknowledgement does not take the place of authentic relationships with Indigenous communities, but serves as one way to honor the land we are on and resist cultural erasure. We also acknowledge that this country exists and prospered as the result of free, enslaved labor of Black people. We honor the legacy of the African diaspora and Black life, knowledge, and skills that have been stolen due to violence and systemic oppression. And we affirm our commitment to be aware of privilege and oppression and how they play a role in the lives of patients, families, and employees as we strive to be anti-racist and improve care for those with less privilege. And this month, we are celebrating Juneteenth, which now is a Seattle children's holiday. And I hope everyone has time that day to celebrate and reflect. And the month of June is also Pride Month. So happy Pride to everyone. And just a note that this year is Seattle Pride's 50th anniversary. So there are some additional celebrations happening around the city this month. Encourage everyone to take part in. I think we'll get started with our presentations. I will hand things over to Doug and Chris.
Thanks to everyone for joining. This is an exciting day. The fellows have, as I think most of you know, a requirement to participate in a scholarly endeavor, which gives them a chance to dig deep into a topic that they're interested in. So the common theme of the presentations is that the fellows are all in about the topics that they're going to share with you, and they're going to describe the work that they put together. Some of it had antecedents even before they started their fellowship, and others were ones that they created while they were here. And just a bit of housekeeping, they're going to go in a more or less alphabetical order with one exception, and I'll introduce the first fellow, and then she and Kind will go on to the next one. Just given the time that we have, each fellow has about 15 minutes or so to make their presentation. That's not much time to summarize 2 years' work, but just given the time constraints that we have, that's what's available to them. And as we go along, if questions come up, Doug Russell is going to be able to join us today, which was not necessarily a given until just yesterday. But if you have questions, you can put them in the chat unless the fellows themselves tell you otherwise, because there just won't be time to take those up during the body of their presentations. And hopefully at the end, if there are questions, then we can have Doug assign them to the respective fellow or fellow pair and have them respond to your inquiries. These have always been good, and I'm excited to turn this over first to Maya and she will she'll begin and then hand off to the next fellow after she's completed. So I'm assuming that the slides are ready to be put up to the extent that there are some, and I'll turn the virtual podium over to Maya.
So my presentation is on catatonia, a case study review. The objectives of this presentation were to examine some case studies of pediatric catatonia in the literature, to describe trends in presentation, to describe trends in pharmacological management, and to examine utilization of ECT in this population. The initial inclusion criteria for the database that I was using was English language, children and youth 22 and under, range of publication years was maximum, and included all cases of catatonia and catatonic-like symptoms. There were 314 cases in this database, and it was created in collaboration with Dr. Amasami, Dr. Shah, and Jeremy Kurtz, who was one of the medical students. I applied some further inclusion criteria for the purpose of this review. I narrowed the age range to 18 and under. I included only cases that explicitly labeled the presentation as catatonia, and I narrowed the years to 1983 and later. This narrowed it down to 160 cases. The reason I picked 1983 and later was because that was the year in which lorazepam was first used to treat catatonia. So I figured that it would be a little more generalizable to our population to look at cases in the post like benzodiazepine era. And if you kind of look at the number of cases per year, this has been increasing over the last few years generally. Just to go over some demographics of this database, patients ranged from 2 to 18 in age with median age of 15 and mean age of 14 and a half. It was split about half male and female with a little more male. Most cases were from, over half were from North America, and this really means the United States. Another third were from Europe, and that really means like Western Europe. And the remainder were from like Asia and Africa. So most of these cases were essentially from the United States and Western Europe. Within the United States, they were split between mostly Northeast and South, with quite a few from the Midwest as well. The West was somewhat underrepresented, though it didn't include cases from like some from Washington, mostly from California. In general, race and ethnic information was not like provided very consistently. So this is what it looked like, but it wasn't very like useful, I think. To go over the clinical presentations, over half the time in these cases, no diagnostic rating scale was used. When one was used, it was overwhelmingly the Bush-Francis catatonia rating scale, which is the one that I've generally been taught to use and the one that I generally use. I went through and kind of like correlated symptoms that were reported with the Bush-Francis catatonia rating scale. The number of symptoms ranged from 0 to 14 in these cases, with a median of 4 and a mean of 4.4. Most of the studies did report symptoms that could at least be correlated with the rating scale. The most common symptoms that were reported were mutism, posturing and catalepsy, withdrawal, immobility and stupor, staring and rigidity. With these percentages, and this is kind of just a general look at all the different domains in the Bush-Francis rating scale. So like some of them were really quite rarely reported, and that might be due to like not really looking for it since they weren't necessarily applying the scale, or whatever. But many of the kind of classic ones were rather rare. Of note, like several of the other very commonly reported symptoms were things like sleep disturbances in 21%, incontinence, whether urinary or bowel in 16%, hallucinations in 13%, and SI and self-injurious behavior were each reported in 3%. 1 in 2 cases had a psychiatric diagnosis, and about 20%, 19% had previously taken a psychotropic. There was a very heavy representation of neurodevelopmental disorders in this data set, which is probably unsurprising to all of you. 42% had a neurodevelopmental diagnosis. The most common ones were intellectual disability and autism spectrum disorder, though there were also like quite a few of Down syndrome and Prader-Willi. ADHD was not very common in this population, actually with only 3%. And in general, comorbidity was the rule when it came to neurodevelopmental disorders in this population. 1 in 3 cases were attributed to a medical condition. Of these, like a quarter of the 1 in 3 were due to like an autoimmune encephalitis. Almost another quarter were due to an infectious etiology, and this was things like PANS, PANDAS, things like herpes encephalitis, things like SSPE, and like a tenth of that third were attributed to lupus. Celiac, Wilson's, MELAS, and a bunch of rare genetic conditions were also implicated. 6% were attributed to drugs. Of those, 2/3 were THC or synthetic cannabinoid, and 1 in 3 were ecstasy. 8% were attributed to medications, and half of those were induced by an antipsychotic. Generally, a first generation, though, there were cases of olanzapine and risperidone inducing like a catatonia as well. Other culprit medications included like HIV therapy, opiates, cyclosporine, phenobarbital. In general, when catatonia in a kid was induced by drugs or medication, there was a pretty good chance that it spontaneously resolved or that it resolved with withdrawal of the offending agent. Let's take a look at like kind of treatment overall. The overwhelming number of these cases received some form of pharmacotherapy, although some remitted spontaneously and some remitted with withdrawal of the offending agent. There was one case that they just went straight to ECT. In terms of response to pharmacotherapy, about a third like fully responded to the first regimen, like about a quarter responded partially to some regimen, and then with some like optimization responded fully. About a third responded partially to medications overall, and about 8% didn't respond at all to medication. Overall, like 2 in 3 cases responded fully to pharmacology. These are the ones where they either immediately found a regimen or they switched into one. More than half the cases which were successfully treated with pharmacology were treated with monotherapy. So the median medications was 1 in successful trials, and the mean was 1.7. And most of these successful medication trials included a benzodiazepine. 29% of successful trials were with just a benzodiazepine. The overwhelmingly common pick was lorazepam, which and the dose ranged from 1.5 to 46 milligrams with a mean of 8.7 and a median of 6. This probably isn't surprising to people who've worked with catatonia. And clonazepam was also a common pick, with a dose ranging from 3 to 6 milligrams and a median of 4.5. Of note, 14% of cases treated successfully with a benzodiazepine monotherapy had failed a prior benzodiazepine trial. Invariably, this was failing lorazepam and switching to clonazepam, usually clonazepam or diazepam. So like failing lorazepam trial may not really necessitate failing other benzodiazepine trials, is what this may suggest. 36% of successful trials were with a benzodiazepine plus other medications. And over half the case, this included an antipsychotic. Always a second generation antipsychotic or clozapine, never a first generation antipsychotic. A quarter of these included an SSRI, and 9% included a mood stabilizer, and 9% included immunotherapy. And then a third of successful trials had no benzodiazepine. A good chunk of these had failed a benzodiazepine trial. And of these, 35%, a quarter of them were with antipsychotic monotherapy, a quarter were with antipsychotics plus other medications, and 12% were with mood stabilizer monotherapy, and 30% of them were with like immunotherapy. And these are, as you might imagine, like your autoimmune encephalitises. In one of the cases, celiac was implicated. and amantadine and a gluten-free diet was successful. In another case, responded to zolpidem monotherapy. I'd heard of using these things for pediatric catatonia, but the number of cases that there was only like one of each in the literature. And then some responded to antibiotics. These were like your infectious etiologies. Overall, 30% of cases responded partially to medications. Most partial responses were to a benzodiazepine. About half of them were to benzodiazepine monotherapy. For these, the lorazepam dosing ranged from 2 to 22 milligrams a day, and a quarter of them included an antipsychotic. 7% of cases that responded only partially ended in death, and 8% of cases had no response to pharmacology at all. Half of these had failed benzodiazepine therapy. Over half had failed antipsychotic therapy. A good chunk had failed antidepressant therapy. And of this population, 7% also died. So this kind of like highlights that pediatric catatonia, when it doesn't resolve, does have like a reasonable mortality rate that we should be wary of. In this database, 21% of patients used ECT. Most of these were in cases where there was a partial or no medication response. A little over half of each of those groups used ECT, which is like rather low, I would think. It kind of suggests that ECT, as we mostly understand, is quite underutilized in catatonia. In terms of the ECT used, it was pretty overwhelmingly bilateral, though a lot of cases did not specify if they used unilateral or bilateral. The treatment counts ranged from 1 to 86, which is really high. And 21% of cases required maintenance ECT, which was actually lower than I expected. Most ECT cases saw complete remission of symptoms, about 2/3, although complete remission occurred overwhelmingly in cases that had a partial medication response. It was quite rare. Only one case actually had complete remission when there was no medication response at all. So probably not too surprising, but some response to medication seems to possibly indicate a higher likelihood of ECT response. 1 in 8 cases considered ECT but did not receive ECT. In half of the cases in which this occurred, logistical challenges were a factor. Most of these cases did end up finding a complete response with medications, but still, like in this kind of database alone, 1 in 3 cases that considered ECT did not receive ECT, and many of them for logistical reasons. And this is something that I think that anyone who's worked on like LCL service can probably appreciate how difficult it can be to get ECT. The process is quite laborious. What are some limitations of like this data that I just presented? Big part of it is that it is a review of case studies. There's pretty major publication bias in this type of literature. Probably an underrepresentation of negative studies, probably an underrepresentation of unremarkable cases. When you look at like the literature about like pediatric catatonia, usually the numbers that respond to like lorazepam monotherapy a little bit higher than what this database suggests. I think usually in the 40-something% often responds to lorazepam monotherapy, or even more, depending on like what review you look at. Because this is looking at case studies, there is an over-reliance on low-quality sources with poor control over methodologies. Methodology was sometimes like quite different in like cases that were not like American or Western European. So that is something to consider. And that is one of the challenges of working with catatonia, is that it's really hard to do a study that is not often somewhat low quality. So, and future directions for the study could include looking at treatment response on a more granular level in patients with specific characteristics like autoimmune presentations, or in like the neurodevelopmental population. And and looking further into the diversity in treatment algorithms based on geography, which was one of the goals for creating like kind of a more global database. So just to go over some takeaways, quality and quantity of data on pediatric catatonia continue to be lacking. Rating scales are underutilized in catatonia presentations. The most common catatonia symptoms in case reports are mutism, posturing, withdrawal, immobility, staring, and rigidity. Psychiatric, neurodevelopmental, and medical conditions are common etiologies and or comorbidities and should always be considered. Drug and medication-induced catatonia should also be considered. Benzodiazepines continue to be the mainstay of catatonia treatment and are frequently effective as monotherapy, overwhelmingly lorazepam being what this is talking about, though multiple benzodiazepine trials may be considered if lorazepam does not work. Antipsychotics, antidepressants, mood stabilizers, immunotherapy, and antibiotics are considerations for adjuncts, depending on how the case presents. ECT is an effective treatment, but is often underutilized, and it does appear to be more effective in patients with at least some response to pharmacotherapy. Thank you. And the next person to go after me is going to be Cynthia Beltran, one of my co-fellows. So.
Awesome. Thank you, Dr. Rowe. To the presenters on our panel today, keep your chat open. I'll be sending you timing notes. We started a little bit late today because of the Zoom link thing, so I'm going to ask everybody to keep to the schedule as best as possible. All right, Dr. Beltran.
All right, so I will be presenting today on the Latino preschool anxiety study, and I'll be focusing on the qualitative data that the parents provided. I like to start out today's presentation with Chucky Finster, because he is who I think about when I think about really little ones with anxiety. And he says, "My mind is a pretty scary place." Okay. I don't have any disclosures. My objectives for today are to provide background on promotoras and what they are, to provide background on the current group anxiety treatment at the Calma Clinic, to discuss the design of the pilot project that I observed, and importantly, to review the highlights of the parent feedback, and that's the meat of what I did. So what is a promotora? So this study uses promotoras to disseminate the material for the anxiety treatment. And promotoras are a culturally sensitive lay health educator for the Latina community. This definition is from kingcounty.gov. They're also known as community health workers or lay health workers in the English language. There are actually several different promotora programs in Washington State, and King County has multiple promotora programs, and just in perusing, they even have them for like breast cancer screening. So a well-established model that's been used in the United States since about the 70s, 80s. So more information about promotoras. Promotoras de salud have been successfully used in blood pressure, asthma, glycemic control. Some other ones are like mammography screening. They've been used in the United States as a strategy to reduce health disparities. The reasons why they may be able to help reduce health disparities are they are part of the community that they're serving. They communicate in a similar language. Language is very particular and very specific to the community that you have. And they may be able to incorporate a cultural promotion of health. So they may bring in their own knowledge of how that culture, manages certain conditions, and promotes just general wellness. And there is also evidence to suggest that they are effective for a variety of conditions. There are many different studies. You can do a quick PubMed search. They have been used for all sorts of things. And though, the evidence that is there is not, there's not a whole ton of like randomized control trials. There are a lot of like pilot projects that have been done all over the country for many decades, that say, hey, this might be a way to help disseminate really important information to the community that, we're interested in serving. And my citation. So what does group anxiety treatment look like at CALMA? So it's group exposure-based therapy with kids of many different ages, just like the Seattle Children's Model for just the mood and anxiety program. Parents and children, depending on the age, and the younger you are, the you only have the parents. It's 9 sessions plus 1 30-minute individual feedback visit at the end. And it's disseminated by typically a psychologist or a licensed mental health therapist. Okay. So I had the opportunity to observe this pilot project in action. And here's the design that they use. So there was an advisory council that was made up of mental health clinicians and parents who previously participated in a CALMA anxiety parent group. They helped assist in the generation of the role of promotoras and helped to refine it. There was also development of online training modules for promotoras. So promotoras are lay health educators, so they need to have some sort of training to be able to disseminate this information. And then there was implementation of the pilot study for the adapted anxiety intervention. So the adaptation is the promotoras. So this is the part that I was able to observe. It was a 6-week anxiety group that was attended by Dr. Trevino, parents, and promotoras. And what makes this different from what CALMA typically does is that promotoras were assigned to a few different families for 20 to 30-minute phone sessions weekly. During these phone calls, they were able to review the material that was presented to families. Parents could ask questions if they were confused about a topic that we had gone through. It was really nice that they were able to kind of clarify those things. They discussed the application of the skills for the family. They did general check-ins about like how things are going with the exposures. They were able to help problem solve barriers. And the other job that they had was to reinforce the family's effort. So a little bit of a cheerleader, if we can call it that. And in order for them to be able to provide this service, the support that the promotoras got was through a supervision group that occurred once a week. And then the last piece of it was there was a participation of both promotoras and parents in a qualitative feedback group. I am focusing on the parent feedback today. So what did my participation look like? So, I got this email that there was a preschool anxiety study, and I was like, I really enjoy working with like tiny, anxious kids. And I'm a native Spanish speaker, so this is super interesting to me. And so I reached out to Dr. Cindy, and she was like, yeah, let's have you join in. So I observed the preschool anxiety group from April to May. They were 1-hour sessions. And I observed a supervision session as well. And then I attended a parent feedback session, and I reviewed additional recorded feedback sessions to be able to compile the things that I thought were meaningful. Okay, so I separated this feedback into a few different buckets. So the first bucket is the presentation of anxiety. So one of the questions that was asked by Dr. Cindy and the other participants of the study group was like, what were the earliest signs of anxiety in your child? And these are all transcribed from the original Spanish. Some of them were transcribed by me, and some of them were transcribed from the study group. So with my son, we had in-home speech therapy. The therapist would come, and while everything was normal, my daughter also had this. The process was like speech therapy, but when he started preschool and then later kindergarten, the school speech therapist suggested that he needed something more. She felt he had another complication apart from speech. She thought it was selective mutism. She referred me to the hospital where they diagnosed him. We found out it was a part of anxiety and his fear of speaking in front of others. And another family provided this. We started to notice, just like other things, that his hands were always needing to have something, and he did a lot of fidgeting. Something that would surprise us was that he would be in our house and him all of a sudden would yell out, "Mama, Papa." We would be in the kitchen and he would be in the living room. Our house isn't big, but all of a sudden he would let out a scream. "We're in the living room." Okay, okay. But then all of a sudden he would run to look for us. We would remind him, "You're never alone. We're always here. Mama, Papa, and little sister." Other questions that were asked in the second bucket of feedback that I think was important was access to care and previous experiences. The first one said, "To tell you the truth, I wasn't aware of any sort of help for anxiety. Like I commented to you, I told the pediatrician, who told me that with time it would pass, but it didn't pass until now I signed up for this program. Thanks to you all. They gave me support. This is how I learned to do that." The exposures. Begin with the exposures and all of that then. It worked for me. And what was interesting is this family shared that they really had to advocate for their child to get services because like providers before the comma clinic had felt like what was described in this quote, that it was a part of normal development. And this parent kept saying, like, no, this is not a part of normal development. Please help me. And here's another parent. He started with his nails. His teacher told us last year around his birthday, I said no and told his doctor right away. She noted it as well, and she referred us to, and it's the name of a local behavioral health service, and it was 9 to 12 months of a wait. He was diagnosed with sensory processing disorder and separation anxiety. So how did people feel about the promotoras? So initially, one mom said that she felt like some discomfort because they're strangers, but that this eventually improved as the process went on. But interestingly, a lot of them shared that they didn't have any hesitations at all. And generally, by the end of the program, people were very appreciative of the participation of the promotoras and would generally recommend them for other parents. So here's some quotes about the perceptions. So in our culture, oftentimes we don't identify anxiety. We say, no, they're little, it will go away. The child is fearful. Well, you see, it's not common in our culture to say anxiety or a type of mental health. We need to learn a little more. Talking with someone and telling them it's okay if there's anxiety in our kids, maybe they'll need a little more help. Talking about the program and how we benefited from the program is how I would talk to someone. At the beginning, while Cindy was telling me that this works, but I didn't think it would work because I didn't see the connection. Talking with the promotoras, they shared their cases, and well, they're already on the other side. It was validating. I don't think that this will have much effect. Having someone with whom to bounce that off of and tells us, no, it does have an effect. I've seen it many times. This really worked. They could do it, so we can do it too. For me, that was their message. Oops, there we go. This was the first program that I, as a mom, have been able to get the skills and also learn. I only knew the basics, but with you all, as well as with the support of the other parents and with the mentors, everyone, it really did help a lot. I enjoyed it because it involved the whole family. And this family actually ended up using the technique with a younger sibling. And my last quote about the perception, because they were, I would like if that there were promoters that they were at one's disposal, because there are at times when you feel very upset and you would like to, but not just talk to anyone, talking to people who went through a test just like ours, someone who lifts you up and someone who makes you see that things get better with our children. I would like this. So there were some suggestions for improvement, and this is the last chunk for me. Many stated that the program was too brief. It was 6 weeks. They were requesting more time to practice, and there were many suggestions to have maybe somewhere around 12 sessions. Though some of them felt it was adequate time. A lot of people were requesting more phone check-ins with the promotoras. Some people said the group was too early. It was, in the late afternoon, early evening on Mondays. It conflicted with dinner. People were feeling too tired from school and work. And parents suggested later hours for the group to accommodate that. And there was an issue of the group sometimes ending late, and families wanted something that was a little more predictable and within the time constraints that they had. And there was limited opportunities to get to know other parents. They really liked the promotoras, but they also really liked the group setting and getting to know other parents in their communities struggling with the same things. And they wanted to hear the promotora stories earlier in the program. They didn't hear them until later in the program, and so they felt like earlier in the program would be better. And a very special thanks to Cindy Trevino. Thank you so much for letting me participate. I learned a lot. It was a really, really cool experience, and I just felt like this was such a great combination of all of my interests. And thank you to you all for being here today. Up next are my two co-fellows, Robin and Roxy, and I'll hand it off to them.
Thanks, Cynthia. So welcome, everybody. This follows on nicely from Maya's talk, actually. So we'll provide some data that will hopefully answer some of the questions or lead to more uncertainty, depending on how you look at it. This study was inspired when Roxy and I worked on the CL service, during which we both cared for young people with catatonia who went on to have very extended hospital stays, and both received ECT, after which catatonia resolved reasonably swiftly. This made us think about ways to find more efficient, management strategies, team working strategies to manage this fickle problem.
And before we get too far into our data, we want to thank everyone who helped us with this project. We've been working with Kyle Steinman from neurology. Dr. Ian Kodish was our faculty advisor on this project. Andrew Given from the Consult Liaison Service has been instrumental in getting our intervention up and running in Epic and with our data collection. And then Carrie Conant was also a faculty advisor on this project before she moved to the East Coast, and she still has consulted intermittently on this. And then Marie from data analytics has been very helpful as well.
I think most of you know what catatonia is. It's a neuropsychiatric syndrome with motor and behavioral symptoms that is one of the most severe psychiatric syndromes we encounter. Diagnosing and treating catatonia is complex and involves great uncertainty, multiple teams, and the need to educate patients and colleagues, which can be time-consuming. It feels like whenever we encounter catatonia, we do lots of soul searching and seem to reinvent the wheel each time. Often this leads to variation in our approach. Catatonia has been described as having intense anxiety and fear in people experiencing it. So patients would benefit from prompt management for these episodes. We heard from Maya about the management that ranges from pharmacology to ECT. Often these treatments involves both risks and extended time. Little is known about how best to taper treatments.
All right, so starting out with this project, our hypotheses were that the workup and management of catatonia is highly variable and may be associated with different treatment outcomes. We also thought that standardizing care for this disorder had the potential to improve clinical outcomes. And we also felt that timely access to ECT can decrease length of stay and time to symptom resolution.
So we aim to identify factors that influence clinical outcomes in children treated at our hospital. We wanted to evaluate the workup and management and compare this to established best practice, to identify factors that delay successful treatments and establish a guideline of care to monitor for continuous improvements.
And despite a prevalence of catatonia of up to 17.8% in psychiatric patients, as Maya discussed, before us, the evidence base for catatonia treatment in children is over-reliant on case reports or series. And while the literature has provided general guidelines on which medications can be considered first or second line, it was not until 2023 that the British Association of Psychopharmacology published the first evidence-based consensus guideline on the management of catatonia. And we thought it would be interesting to see how well we comply with these new recommendations, and that this comparison could inform what elements of our current management we could improve.
So following IRB approval, we conducted a retrospective chart review, all people under the age of 18 who presented with first episode of catatonia between January 2018 and April 2023. We chose first episode because it gets very complex once somebody presents a second and a third time, of which those were numerous. And we wanted to just keep our data as simple as possible, with the aim of being realistic. So we collected data on demographics, the nature of assessment and treatment, and relevant timings.
So let's start with some information about how our patients are presenting for treatment. So Asian patients were overrepresented in our sample at 27%, as well as Black and African American patients at 22%. Compared to all patients presenting to Seattle Children's Hospital and in Washington State. We got that data from the most recent census. The insurance of the presenting patients and all patients at Seattle Children's were quite similar. There were more male than female patients in our sample. We had 45 patients total, and 10 of those presented prior to the start of the COVID pandemic. So interestingly, the presentation of catatonia increased quite a bit after COVID started in Washington State. And as you can see, we had 3 patients presenting in 2019 and 9 presenting in 2020. We tried to see if there was any one category of comorbidities that could account for this increase. However, all psychiatric catatonia comorbidities increased after COVID. The only category that decreased was other medical, which we use to capture patients with a medical diagnosis as the underlying cause of catatonia. And also neurologic comorbidities stayed very similar. In our sample, only 6 patients had COVID when they were diagnosed with catatonia. And also there was a subset of patients in our sample who were diagnosed with catatonia and managed in the outpatient setting. And this practice decreased quite a bit after 2019. There were also 2 patients with suspected intellectual disability and nonverbal autism that weren't formally diagnosed, but they may have increased the prevalence of autism and intellectual disability after COVID started. And then 42% of the patients we had in our sample were on an antipsychotic at the time they were diagnosed with catatonia. This word cloud represents presenting complaints of patients diagnosed with catatonia. And as you can see in this chart, this is what the primary team documented as possible precipitating factors for first episode catatonia. So the COVID pandemic was cited quite a lot. Psychological stressors were the next most common, and then antipsychotic use was the third most common precipitating factor.
All right, so we'll move on to assessment and management. We can see that when evaluating for initial management, we found that 62% had consultation with neurology, less than half had any form of recommended investigations, and strikingly only 70% had standardized rating scales. Note that what we've labeled here is BF-CRS or Bush-Francis catatonia rating scale. We'll talk more about that later. also included patients who received another evidence-based rating scale like the pediatric catatonia rating scale. We also see that rating scale use increased over time. In 2023, there were only 2 patients in the study, and actually both of us had encountered, Roxy and I were involved in their care briefly. The rate of inpatient rating scale involved the number of scales administered divided by the number of hospital days. And we can see this remains low but stable. Ideally, rapid changes to benzo doses should be measured, so this could be an indicator of quality of treatments.
And then just for some context, these are the 2023 consensus guidelines on the workup for catatonia, which does recommend that patients, particularly those in their first episode or situations where the underlying cause is unclear, should get these laboratory and imaging studies. And we reviewed our draft guideline of care, which does recommend these workup elements with neurology, and they agree that they should be consulted for everyone with a first episode of catatonia, and that we should err on the side of more investigations prior to initiation of treatment.
All right, this chart represents the maximum daily dose of benzodiazepines in lorazepam equivalents each year. As you can see, the average has been increasing annually with high variation. We found that 45% of patients remained on benzos at the end of the study period, often despite symptom resolution. At the bottom right, you can see that the active symptoms of catatonia play only a very small role in the patient's catatonia journey. They spend much more time being treated with medication than they do experiencing active symptoms. Because many patients remained on benzos at the time of last clinical contact, we separated groups into patients who were successfully discontinued, shown in orange, and those still on benzos, shown in gray. That's a limitation of our study, that we had to separate that out. More time to follow up would hopefully answer that question. But there were also a number of patients who moved to Ethiopia on 16 milligrams of benzos every day, or just we simply don't know. After 2 weeks after discharge from the PBMU, there's no notes in EPIC.
And so as we saw on the previous slide, we are moving toward more patients getting what would be considered an adequate medication trial of benzodiazepines, which suggests that either our providers are getting more comfortable with these medications in catatonia, or the symptom presentations are becoming more severe. There were also many patients in our sample that were on more than 16 milligrams per day who eventually needed ECT. So perhaps we could be considering ECT earlier in those cases requiring higher doses of benzodiazepines.
This graph shows the duration of different checkpoints and treatment over time from 2018. Light blue is symptom to diagnosis. Dark blue is diagnosis to symptom resolution. The bright blue shows patients who had benzos successfully discontinued, and orange are the ones who were lost to follow-up. So you can see that many of them that just cuts off, that's actually May 28th this year. But some of them, we lost follow-up while they were still on benzos, according to the last clinical note we could find. There's no clear correlation between untreated symptom and resolution time, or between symptom duration and benzo taper time. You can see this is just highly variable.
So of the 24% of our patients who reached the 16 milligram lorazepam per day threshold for what the consensus guidelines describe as an adequate trial, only 54% received ECT. And as you can see, these patients in general had longer hospital stays. However, ECT led to faster symptom resolution than medication management alone, with one outlier. So 6 patients had ECT, 3 had the process started, but symptoms resolved while waiting for ECT, and an additional 2 went on to have ECT after discharge, which are not captured here.
All right, so let's talk about outcomes. And, this is really perhaps the most interesting and frustrating part of this study. So to measure treatment outcomes, we identified 4 measures. We looked at admission duration, symptom duration, the maximum benzodiazepine dose, which can be a proxy for either treatment resistance or for complexity, And then to show benzo discontinuation, as I spoke earlier, we did not know this time for all patients due to loss of follow-up. We identified groups, those that were off benzos within the median duration of 272 days. Now that number is the median duration for all the patients that got off benzos. And we took that time and just made two groups, those that were off benzos by then and those that were not. That made a kind of category distinction in the data, which leads to a huge loss of statistical power. So before we write this up, we hope to speak to a friendly statistician and help us find there has to be a more nuanced way to do that. Data was skewed and highly variant, so non-parametric tests of significance were used. And it's important to acknowledge that as this is an exploratory study with the purpose of quality improvements, our intention was not to test hypotheses. So we did not correct our p-values for multiple significance testing. What we really wanted to do was just say, look, there seems to be a signal here. Are these groups even statistically different from each other? So therefore, we thought that with, humble acknowledgement of that it was appropriate to do so. The only significant difference we found was for people identified as Asian who had longer or higher benzodiazepine doses compared to other races. There does seem to be, looks like there's a signal in orange here, which shows symptom days in Hispanic and Latino people, but there were few numbers and that was not significant. There's a lot of data on this slide, and I apologize for that. What we are showing here are the 4 categories for treatment outcome, and I'll talk about bar charts first. We can see that the orange indicates those where the groups were significantly different. And we can see that for Medicaid was associated with a lower median admission days than for commercial insurance. We can see that COVID status at the time of admission, so COVID positive, was associated with higher benzos, as was underlying psychosis at the time of discharge from hospital with catatonia. So we can posit that that could be an underlying cause for the catatonia. Psychosis was also associated with higher admission duration compared to those without psychosis, which kind of makes sense because, it's perhaps a marker of complexity. In terms of likelihood of benzodiazepine discontinuation, we calculated odds ratios, and we can see that none of those are significant. The confidence intervals are wide, but all crossed 1. However, we did see that there is a potential signal, had we had more power, that Medicaid may be associated with lower, or higher likelihood of benzodiazepine discontinuation 3 times. Neurology consultation was associated with a lower likelihood of benzodiazepine discontinuation, perhaps. Maybe that's a marker of complexity as well if neurology were consulted. It would be great to get more data so we can tighten these confidence intervals and perhaps find significant values. I also think that our, group distinction of 272 days, which was the median time, perhaps if we shortened that. But now we're getting into the realms of massaging the data, and we wanted to just not do that and present what we had.
Great. So we had all of this data and we had to decide where to start implementing changes. So we went back to the consensus guidelines to see how we matched up. And there were 2 mentioned that mentioned the importance of using a validated rating scale, both in terms of diagnosing catatonia and also in terms of research. They recommended that a rating scale should be used and that individual items should be defined in a coherent and consistent way. So we decided to have the Bush-Francis catatonia rating scale incorporated into EPIC as a flow sheet. And the reason we decided to use the Bush-Francis catatonia rating scale instead of another rating scale like the pediatric catatonia rating scale is that it is the most widely cited and clinically used scale worldwide and within the Seattle Children's Hospital system. It's the only scale to be validated by a lorazepam challenge. It has been found to be sensitive to changes in clinical status in response to treatment. It has been validated in a pediatric population. And there are videographic resources available freely online that show how each of the measures should be recorded and scored. So in case you haven't seen these already, these videos are available at the University of Rochester website, and you can look and see how each of the symptoms present and how to score them 1 through 3. And then these are just some screenshots of what our flow sheet looks like in Epic now. So you should be able to go into Epic and hover over each of these elements to see how they're defined. And then from the drop-down menu, when you're entering the scores, you can see like what a 1 would be or what a 2 would be for each of these elements. And then there's a free text, several free texts at the bottom where you can include the total daily dose of benzodiazepines, other notable medication changes or events. So you can score like this rating scale was used before ECT or after ECT. And then there is an area for additional symptoms of concern, and we included a drop-down menu for symptoms included in the pediatric rating scale, like incontinence and acrocyanosis. So you can include those there. And then if you don't want to have this whole big flow sheet in your note, there's also a dot phrase to have just the total score. And that goes back over time and across encounters, so you can see how the score has changed over time.
I think that, we will release a job aid on how to use this. It really is hot off the press. As of yesterday, they're saying, oh, you might be able to see it now in Epic. It'll be under screenings as well. A really cool thing is that we will be able to pull data from the Bush-Francis flow sheet into Tableau. So instead of, Roxy and Andrew Given and I spending hours and hours pouring through Epic looking for chart notes, this data is going to auto-generate over time. So we just need to give more time, and it would be cool if we can do things like hypothesis tests, do kind of motor symptoms of catatonia or like narrow phenotype catatonia. Does that correspond to shorter treatment duration or better outcomes than more non-specific symptoms like withdrawal, which could have multiple causes, all of which can get better with benzos, by the way. And, so it might allow us to kind of really generate some interesting hypotheses going forwards. All right, so these are, the ideas we have. So we have the Bush-Francis catatonia ratings, which we will be releasing shortly. We have a guideline of care based on the British Association of Pharmacology guidelines, which are the only ones available at the moment, which is currently being reviewed by neurology. That's going to be a work in progress that's going to take time. We would love a first episode of catatonia order sets, partly to remind us what to do, partly to have nursing comments. We need to screen things like, risks of immobility, are people eating and drinking? We want to monitor all that kind of data. We would love to have information and guidance on family education and communication. We'd love to have a discharge dot phrase that could give specific recommendations for the ongoing management of catatonia and benzodiazepines. Improving access to ECT now. We hope that ECT will come to Seattle Children's, or there'll be a kind of faster way of getting ECT. Maybe there's an advocacy branch to that in kind of improving ITA law to allow kind of emergency ECT at a swifter basis, which is possible in other states and countries. So there's lots of cool ideas where we can take this project. Roxy and I want to continue to be involved, but we'd also want to inspire another fellow to maybe, collaborate with us and carry on this project, because this is actually a big project that's going to take a long time and it's sorely needed work.
So we have Dr. Brenda Cartagena Barrera next.
So I'm gonna present this project that started a few years ago, and is now it's gonna happen at Seattle Children's. It's trauma-focused cognitive behavioral therapy groups with cultural adaptations for Latinx teenagers and their caregivers. Now, during this talk, I'm going to be using TFCBT just to make life easier for everyone. And yeah, so just to tell you a little bit about me, I am from Mexico and I did my residency training in New York. And I experienced the frustration that a lot of providers have experienced of not having material that can be used for families that are not English speaking, specifically when we're trying to educate them about, mental illness and more, about their children's mental illness and what they can do for, as parents to help them, during their recovery. So that's what led me to apply for an APA fellowship that SAMHSA was also helping, giving the money, and they gave me they gave me the resources to write a children's book in Spanish about PTSD with a guide for caregivers, because we're talking about maybe 5 years ago, I could not find a single book in Spanish about PTSD that had, again, a guide for caregivers. So I was very happy about that. This is me 5 years ago with the person who illustrated the book. This is the cover of the book. And by the way, like if you want a copy of the book, I have a lot of them and they're for free. So I mean, again, SAMHSA is sponsoring it, so I cannot sell it. I promised that I was not going to sell it until I finished like the 1,000 copies that, I was able to print. So the other, and just having the book was one thing, but I was, the other part of the problem was like, okay, now what do I do with the book and how can I implement it, as part of the treatment with my patients? So this is how the project started. Now, the objectives of the talk is, number one, to understand the need of having accessible tools to treat and prevent sexual trauma in the Latinx community. The second one, to understand the benefit of using modified TSCBT groups with cultural adaptations for the Latinx community. And the third one, to explore the application of online TSCBT groups. And especially this is, the TSCBT groups online, there's no single, project that is with Spanish CSBT groups. They are just in English, and as you can imagine, they started because of the pandemic, right? Now, let me give you just briefly introduction. Latinos, last census, 80% of the United States, and in 2060, it's going to be almost 1/3 of the whole, population in the U.S. So we have to be prepared to, to serve this community. And, when we talk about just specifically trauma with Hispanic women, I found this like also shocking. And this is why also, I found myself very interested in creating this project, was because according to the National Intimate Partner and Sexual Violence survey, 13.6% of Hispanic women have experienced rape in their life, and 35.6% Hispanic women have experienced sexual violence other than rape. So we're talking about that almost half of Hispanic women have experienced sexual trauma. So that's a lot. Now, let's talk about TSCBT. Why TSCBT? Well, it's an evidence-based treatment that is for, decrease the symptoms of kids that have experienced traumatic events. And it's very interesting because what it entails is that the treatment involves the parents, which I think this is very important. So it's the kids, the parents, and a therapist. It's already, there's a guide of how you can do this type of treatment. It can go from 12 to 20 sessions. And the age is for, 3 to 18 years old for the kids. And there's already some randomized control trials that, they have shown that this type of treatment decreases the symptoms of NDD, PTSD, and GAD by 40 to 70%. Now, the question is, if it's so good, why we're not using it? Well, is that we need one provider per family, and it's expensive. To get certified in TSCBT, it's almost like $1,000 per person. So it's not that simple to get the certification. Now this is just, how it looks like the treatment of TSCBT, and I'm gonna tell you a little bit more about it in a little bit, but I just wanted to, to put it out there. So the question now is like, okay, so we have the Latinx community, there's a lot of sexual trauma, for females at birth. TSCBT exists, but there's a lot of limitations with it. And also, don't even start me with the amount of Spanish-speaking providers that, there's a lack of them in the US. So, well, it's like, okay, a solution would be to create groups. So that way, we can reach a larger number of people. And also, it can help to reduce feelings of shame, isolation, and stigma, specifically when we're talking about sexual trauma. So this is where the idea of the modified TSCBT groups is starting. I did the first part of the project in New York, and we were doing in-person groups. And the hypothesis was, that these modified TSCBT groups was gonna, help, it was gonna improve the symptoms of NDD, PTSD, and GAD. The methods, just tell you the inclusion criteria, it's for the ages of 13 to 17, female at birth, and the kid had to have a documented history of sexual trauma. And for the parents, an important inclusion criteria was that the parent has to be aware of that the sexual trauma exists. We didn't want to give them the surprise in the group. And the exclusion criteria that the kid had to, the kid could not participate if they have an active SI in the last 6 months, if they had a hospitalization in the last year, and if they were still living with the perpetrator that inflicted a sexual trauma. And for the caregiver, big exclusion criteria is like they could not be the perpetrator. Yeah, that was one of the things. So how it looked like is that we had actually a group of 7 kids with their respective caregivers, total of 12 sessions. The kids will come to the hospital. And we're talking about, like, in New York, some people will travel like more than an hour just to get to the hospital. So moms will go to a group that it was run in Spanish, 45 minutes. The kids will go to a different group, 45 minutes. And also, as many of you know that, work with Latinx families, there's a phenomenon that kids prefer to speak in English. And as you can imagine, that affects a lot the communication between parents and their kids. So, we wanted to be accommodating. So, the group of 4 kids was in English, 45 minutes. And at the end, we have a conjoined session with everyone. But we were forcing them to speak Spanish, everyone, because they know it's Spanish. They just don't want to, they just want to speak. Okay. Now, as I say, these are this is what entails TSCBT, which, it has like some, what we do is that we educate the family, the kids, we teach them like some relaxation techniques. And at the end of the day, the purpose is that once we go through the trauma narrative, the kid has the coping skills that they need in case, if, they get very triggered. And also the parents know what to do with their kids when the kid gets, triggered at home. Now, the modifications that we did for in this group was like, one, we took into consideration the generational trauma of the caregivers, which, it was fascinating to hear what the moms have to say. All of them, by the way, were moms. Parents, dads were invited, but moms were the ones who were showing up. We were discussing the challenges of talking about mental health just in general in the Latino household. And we used the book that I just showed you, La Valentía de Pancho. And funny, for the relaxation part, we were just going to do the progressive muscle relaxation that is in the regular TSCBT, but the moms stopped me and they were like, we don't like this. And I was like, okay, so what shall we do? And they were like, why don't we pray together? So anyway, I found myself then, using my religious background and putting together, making up a prayer there with the PMR. And, with my team at the end, we decided just to create some prayers that we could, do at the beginning of the sessions with the moms. The kids didn't like, with the kids, we didn't do that, but the moms, that's what they liked. And for the trauma narration, for this one, we have individual sessions in their preferred language. And again, like when we were with the moms and the kids together, we did it in Spanish. And we encouraged, again, like the use of Spanish between the kids and the parents. And in the case that it was in person, we had meals with some activities for everyone. Now, just to show you how the book looks inside. So this is Dr. Flatface or Dr. Chato. He's a psychiatrist, and the story is about Pancho, the dog that it's traumatized and, goes through all the PTSD symptoms, and how, Dr. Flatface helps him, recover. So, it also, I think it helps with, reducing the stigma going to see a psychiatrist, and also the fear that a lot of families have of like, oh my gosh, a psychiatrist, something is really wrong with my kid. But no, we know that that's not the case. And it has at the end, like a guide for the, the parents or caregivers, also with questions and answers, that are very simple about, trauma just in general. So now going back to the study, what we did is that we, and this was for the moms and the kids, we got the ACE scores of all of them. And, depending on, if it was a group of adolescents or the caregivers, we screen at the beginning, for MDD, PTSD, and GAD, and we repeated the same, we repeated those same tests at the end of the TCBT treatment 6 months later and a year later, right? Because we wanted to, see if actually the results were sustainable. And just really quick, the data that we found, as you can imagine, right, like ACE scores were high. And we were very happy to see that it was statistically significant, like the reduction in the symptoms of depression for the adolescents and also in anxiety. And the parents actually, because we use this care like person for the parents also, notice that their kids' levels of anxiety decrease. We had a retention of 100%, with which, we were very happy. And again, there were a couple of families that were traveling more than an hour just to come to the group. So that was for us like very, shocking, but we were very happy with that. So again, TCBT groups, just as a discussion, can be an efficient way of decreasing PTSD, MDD, GAD. And, especially when we don't have enough mental health providers. And this modified version that, with the cultural adaptations, I think that, it can be a way of retaining, treatment in minority groups, not just for Latinos, but, I think that there should be, more modified TCBT groups, depending on what, community we're targeting. Now, I think that the other part is that, and this is in general for all TCBT treatment, and not just the modified, but yeah, I think it's very important to take into consideration the caregiver's trauma and how that affects actually, their relationship with their traumatized child. And now we think that, this could be replicated. We have the material there, and, the other people that are working with the Latinx community can use it. The paper is going to be published hopefully soon. It's still in revision, but yeah. The limitations, of course, is that this was a very small sample size. We cannot compare, if actually this modified version is better than, just the traditional version. And the distance, again, was a limitation for patients. And that's why here in Seattle, we were like, okay, why don't we do an online version of this? So I'm very happy that, we have a mentor, Michelle Dick, and one of my co-fellows, Cynthia, is also helping us with this, which is going to be exactly the same project, just that it's going to be an online version of this. Same hypothesis, again, like just adding the online part. We still are working with the IRB because you can imagine that, as a vulnerable population, females, victims of sexual trauma, children, they have a lot of comments. So we're working on that. And, the difference, I would say, in the inclusion criteria is that they have to have availability to an electronic device, and also to have a private room where they can have the sessions separately, the adolescents and the caregivers. But yeah, the exclusion criteria is going to be the same one. And, in terms of like future directions that we have, with this project, is that, now we're going to be able to compare, the online version versus like the in-person version. The book, just put a comment on there. It's already translated. We're just I'm just waiting to become an attending and have money to print it. But thank you, Maya, one of my co-fellows also. She did the translation. So I'm happy about that. And we're going to restart the website. So we have Las Aventuras del Dr. Chato, which is, the idea is that there's going to be, again, Dr. Chato's Dr. Flatface is a psychiatrist, child psychiatrist. So the idea is that there's going to be different books about Dr. Flatface treating different, mental illness. And again, like decreasing the stigma of seeking help of a mental health provider. And sorry, maybe I'm just speeding up, but you want to be mindful of the time, but thank you. Yeah.
And next we have Dr. Samala.
But my project is about including perinatal mental health topics within child and adolescent psychiatry didactic curriculum. Some objectives for this presentation is to talk about the current state of perinatal mental health training amongst all psychiatry residents, so also including adults, recognizing the importance of perinatal mental health for children and adolescents when working with these children and their whole family system. And then also formulating ways to increase collaboration between women's mental health and child and adolescent psychiatry departments. And I think overall, part of the reason I'm interested in this is to sort of have everyone start thinking about ways that we could have more overlap between perinatal mental health and infant early child, especially. Personal background, just my interest here. I've always been interested in women's mental health and as well as child and adolescent. I love the focus on early childhood and multi-generational health and working with parents to help them kind of, work on their own parenting skills and therefore help the next generation as well as themselves. And then as I've been going through training, I have noticed this pretty significant siloing where perinatal mental health is adult, infant early childhood is child and adolescent psychiatry, and there's not always a lot of overlap despite, a very clear sort of transition point with the birth of a child from one to the other. And then just added here too, no disclosures for this talk. So this is kind of just what I was saying a minute ago. So we have this one silo, which is parental support, reproductive psychiatry, housed with the adult psychiatry side. And then we have this other silo, which is infant mental health, child and adolescent psychiatry, but they don't connect really. It's hard to have overlap. And obviously this is not ideal if we are talking about treating entire family systems. Silos no more. This is kind of the ideal, as we have perinatal, we have infant, and then we have this beautiful bridge connecting services, connecting support, and much better for everyone. So again, overarching goal of sort of this project and this content overall, ideally, a smoother transition from pregnancy to postpartum time period for the birthing parent, for the infant, for the entire family system. Ideally, increased collaboration between child and adolescent psychiatrists and perinatal adult psychiatrists. Also could be additional collaboration between child and adolescent psychiatrists with OBGYNs, PCPs, and pediatricians. And ideally improvements in preventative care, ensuring secure attachment between caregivers and children, possibly even early referrals for services for at-risk children and their families. Specific project goal, trying to think of a way, that's more, I guess, doable in the short term. So the specific project goal is to include perinatal mental health didactics into the child and adolescent psychiatry didactic curriculum at Seattle Children's. For now, would be split into 1 hour talking about psychiatric medication use during pregnancy and then common mental health diagnoses in pregnancy, another hour talking about substance use disorders and treatment during the perinatal period, and then a third hour to talk about psychosocial supports and local referrals. For those who aren't in the psychiatry, psychiatry training part of children's, our didactics are split usually into 3-hour sessions of once a week. So it would essentially take up one of those periods of time. Relevance of perinatal mental health for child and adolescent psychiatrists and trainees. One, I think the focus continues to grow for the importance of intergenerational and dyadic work with families. And also, if you're treating someone in the perinatal period, that's really the earliest intervention you can have for infant mental health. Caring for the parent is caring for the child. And also especially working with early children, but overall, if child and adolescent psychiatrists feel confident answering parent questions or knowing what referrals to provide if parents have questions about their own mental health, that is always going to be good knowledge. This can be applicable to non-birthing family members as well. And in some ways, we do already talk about perinatal mental health in our didactics. We always talk about Ghosts in the Nursery, which is a very important study in early attachment. We talk about FASD and other in utero exposures, which involves the birthing parent. So we are talking about it. I'm just hoping to expand. And then let's talk briefly about the current mental health, perinatal mental health training in psychiatry. So currently, this is speaking to adult residency where we all trained prior to CAP fellowship, but there are no competency requirements in child and adolescent training for perinatal mental health. There are also no competency requirements in adult psychiatry training, no requirements for programs to include perinatal concepts, though this is evolving. People are recognizing the importance. There are women's mental health fellowship programs that are about a year long. They're not standardized, so they could focus on different things. There's no ACGME board afterwards and no formal certification process. These fellowships are more, again, kind of like gaining knowledge on your own, but there's no like national standardization board of someone being recognized as a subspecialist. Recent data, this was a study in 2015 that showed that only 59% of programs were requiring any sort of reproductive psychiatry training or education. And program directors were surveyed, and only 36% of those surveyed actually thought it was an important competency for residents. So I think that's important to note. Here's some pictures and all these slides of our fellowship class, my class in the year below. There's 13 of us total. And I surveyed everyone just asking about their previous perinatal mental health experience, with my thought being, if everyone's had very robust training, maybe it's not necessary. But in terms of didactics, 87.5% of people said they did have some. One person, 12.5%, had none. The range was very broad, though. So one person surveyed, these were anonymous, I don't know which fellow it was, but someone had 30 hours, which was quite an outlier. As such, did the data both ways. So the average amount of total perinatal mental health training within a 3 to 4 year residency for our fellows was 3.5 hours, 6.5 including the outlier who had more time. And did indicate also someone had done an elective where they sought out extra time. Asked about treatment of perinatal patients during residency, 100% of our fellows have seen perinatal patients with a total of 3.5 hours on average of focused didactic time. Range of how many hours spent with these patients, 4 to 40. Again, one person had done an elective, saw 180 hours of perinatal patients. So the mean time was seeing about 20 hours of perinatal patients with 3.5 hours of formal didactic education about these populations. Consequences for birthing parents of not having a well-trained psychiatry field in perinatal mental health, undertreatment of mental health and substance use disorders overall. There's a lot of provider discomfort in using medications, which often leads to people being undertreated or told they can't use certain medications that maybe they could. Consequences of just untreated mental health during a very stressful transition point into parenthood. And then also, this is from another study done in 2015 saying that because we don't have enough providers trained to give good, nuanced, robust information, parents tend to look to either formal websites or social media to find this information. And analyses of these media sites has shown that there's a great overemphasis of risks of medication and a great underemphasis of what the actual risks are to parent and child of untreated, anxiety, depression, etc. during the perinatal period. Consequences for offspring. We know there are risks for pregnancy and delivery of untreated mental health conditions, including low birth weight, preterm delivery, intrauterine growth restriction. There's also a higher risk of infant mortality overall. There are negative effects on early parent-child attachment, and also long-term consequences for children, including socio-emotional, cognitive, and physical outcomes. Also greater vulnerability for psychopathology in early childhood and as these kids get older. So perinatal mental health does have relevance for the children that we treat. And then, again, just some special populations, kind of ways to think about how child and adolescent psychiatrists could have a unique role with these populations. Adolescent pregnancy rates continue to decline, which is wonderful, but if adolescents are pregnant, young adults are pregnant. I actually spoke with someone from the women's mental health team at UW, and they were saying they don't really have a good system for adolescent pregnancy. Adult providers tend to be uncomfortable treating people under 18, but because they're pregnant, some child and adolescent psychiatrists might not be comfortable. So it's kind of a tough spot for a pretty vulnerable population. NICU populations is an underutilized place for child and adolescent psychiatrists. Also talking just about pregnancy loss, kind of counseling through that difficulty, child and adolescent psychiatrists could be beneficial. In terms of just navigating the family system, identity changes after pregnancy for family members, and then also child and adolescent psychiatrists tend to involve the entire family and the broader community when working with populations. Two examples of programs that do a good job of including perinatal mental health within child training. This is University of Colorado's Division of Child and Adolescent Psychiatry article from 2022. They explicitly describe that infant mental health populations begin with expectant parents, so they include the perinatal period in their treatment. They always include all members of the family system, all attachments, not just the birthing parent. And also, what I thought was pretty cool, they have child and adolescent psychiatrists providing consultation to the NICU and also have pregnancy loss groups and to provide a lot of support to families after experiencing pregnancy loss. UCLA similarly has a clinic called the Moms Clinic, focusing on perinatal mental health with a lot of child and adolescent psychiatrist involvement. There's two quotes from an article in 2022 I really liked. One is, along with the birth of a child comes the birth of a mother, or parent, I would say, to more broadly. And also, infant mental health does not exist without treating the caregiver. The consequences of a one-sided approach can be catastrophic for a family. Just again, speaking to this importance. They do a lot of collaboration between psychiatry and OBGYN. They also have child and adolescent psychiatry trainees embedded in OBGYN who start treating the family unit prior to delivery. So they're working with a parent during pregnancy, ideally, helping to reduce continuation of intergenerational trauma. They really are working in this diet at the earliest intervention point in pregnancy. They also are gaining exposure to infant observation, especially, very early newborn infants. Again, specific project goal, just 3 different hours of kind of different focus. Surveyed my fellows about these specific topics. So ranking scale of 1 to 5 of comfort level treating various pieces of the perinatal period. First question was talking about describing psychiatric medications during the perinatal period. 50% somewhat comfortable, 50% comfortable. No one is very comfortable, feels super confident in this. Next, talking about treatment of bipolar disorder or psychosis, more discomfort. So 37.5% of people say they're uncomfortable or somewhat comfortable. 12% did say very comfortable, but in general, more discomfort when it comes to these diagnoses. Treatment of mood disorders, anxiety, and OCD, more comfort there. Everyone, kind of evenly distributed, somewhat comfortable to more comfortable. And I think these we more commonly talk about. So to me, it makes sense that there's more comfort here than these other disorders. In terms of, what would an hour of talking about psychiatric medications and mental health involve, we would talk about current data based on the Pregnancy and Lactation Labeling Rule, PLLR. Pregnancy risk categories previously used, like category A, B, X, etc., were removed in 2014. And now counseling is based on narrative data where the risks and supporting data for these risks are just kind of talked about more in a more nuanced way. We'll talk about specific medication classes, any dose adjustments during pregnancy. And then also, I think this is very important in these populations, is talking about the very nuanced decision of individual patient need. And sometimes medication with a little bit of risk is better than untreated and of mental health conditions, and it really just needs to be based on that individual. Talking about risks of untreated mental illness for both the birthing parent and the infant, and then also talking about use of medication in breastfeeding. Now let's talk about substance use disorders. Less comfort here. 57% of fellows feel uncomfortable talking about perinatal treatment of substance use. And then, a little under 50% feel somewhat comfortable. Notice no one is comfortable or very comfortable. So the second hour of substance use disorder discussion would be overview of common substances, risks of exposure to mom and baby, talking about the SAMHSA clinical treatment guidelines, and then also medication treatment options for treatment of substance use disorders, risks and benefits of these during the perinatal period, and then also monitoring guidelines. And then also want to outline some resources for expecting parents. Hour 3 focused on psychosocial aspects and then also local referrals. Asked fellows about their comfort counseling on the transition to parenthood, any newborn care needs. 37.5% of people would feel uncomfortable answering these questions. And I think in early childhood, if anything, the psychosocial piece, I think, will come up for us even more. And then, as you can see, 12.5% very comfortable, 37.5% comfortable. So a little bit split here. This, I think, is very important. Are you aware of local perinatal mental health resources and the referral process for these resources? 87.5% of our fellows don't know what resources are available for perinatal patients or how to refer to those resources. So psychosocial aspects, hour 3, talking about societal expectations and stigma. Parents face a lot of stigma with their care choices, breastfeeding, returning to work. There's judgment all around, and resources will say one is right, one is wrong. This will affect children, affects the whole family system. These expectations are true for birthing and non-birthing parents. And then other identities can also affect this stigma and these expectations, be it sexual identity, relationships, parenting that isn't, mom, dad, gender, race, socioeconomic status. All of these things affect what families experience when they transition to parenthood. And then also there is overall a lack of accessible and non-judgmental parenting information. A lot of it is, if you breastfeed, that's the only way. If you use formula, that's the only way. And it makes parents often feel like they're doing it wrong no matter what. And then just more of psychosocial aspects. Transitioning to parenthood. This is applicable for first and subsequent children. I think people forget that, bringing a second baby home still is a lot of changes to the family system. So I think that's important to talk about. Intimate partner violence can increase during the perinatal period. So talking about that and resources for that. Also some early infant care and sleep hygiene training, nutrition, etc. I think it's also important to just be nuanced about this and individualize recommendations for family and really focus on a non-judgmental attitude. Also talking about, shifting identities, becoming parents, talking about parental self-care during this transition. Important to normalize all experiences and all feelings. That's, I think, really what families need more than anything. Transitioning to parenthood is feeling like their choices are encouraged and, it's acknowledged that they are trying their best in a very difficult and, I would guess, energy intensive time, I guess. For the sake of time, I won't go into all of these, but basically, all these slides are a list of many perinatal mental health resources. PCL line for providers where they can call and ask questions. mothertobaby.org provides really good information about medication use in pregnancy and breastfeeding. I use this a lot with patients. Barnard Center for Infant Mental Health. And then this Perinatal Support of Washington is great. There's a lot of good parent resources, home nursing, peer supports. I won't go into it for time. Swedish has an outpatient PHP program for moms and infants are included too. And then Open Arms, Perinatal Services. UW has a parent-child assistance program focusing on home visits for parents with substance use disorders who are expecting or have young children. King County also has a lot of resources. So again, I won't go into them for time, but next steps for me, hoping to implement this in the next didactic calendar. We have a 2-year cycle, so it essentially would be, that 3-hour session every other year. So each fellow class would get the content, continue to update that content based on new data and also fellow feedback after each iteration. On a national level, some next steps. There's a national task force on women's reproductive mental health goals. They're working on developing a national standard for reproductive psychiatry education and then also just clarifying the subspecialty so it's a little bit more clear who is a perinatal psychiatrist and what are their credentials. Some future directions, possibilities, ideally improving the referral process between child and adolescent psychiatry, perinatal psychiatry, and providers like OBGYNs and primary care doctors. I think embedding child and adolescent psychiatrists in the NICU could be a really great direction too. Increasing collaboration between, the early childhood clinic at Children's and then UW's reproductive psychiatry service. For example, could we do co-occurring referrals? Could we do co-occurring treatment for parents and infants? These are, again, just more possible ideas. And then on a national level, expansion of mother-baby inpatient units and intensive outpatient programs to really still focus on that early attachment, despite, maybe needing a higher level of care. Quick thank yous, Dr. Hemke at Children's and Dr. Amrita Bhatt at UW have been very wonderful in their guidance and mentorship. The curriculum committee here, including Doug Russell, who is here, have been very interested in this and very supportive of my interest in adding these topics. So thank you. And then Dr. Chris Riley, Carrie Williams have been very helpful in coordinating projects for all of us. And here's some references if anyone's interested in what I referenced. And next, I am happy to introduce Dr. Christina Warner.
I have it on good authority that I am the last presenter, so thank you all for hanging in there. I'm going to try to be expedient. These slides, I think, will be available should you have more interest in it. And I'm always happy to talk kind of in more detail, but I would like to leave time for questions. So I will be talking about gender diversity and autism spectrum disorders and some opportunities that we may have to be better clinicians. Objectives, I will be talking about the prevalence of various things at the Autism Center. And then I'm also going to talk about kind of the process that we currently have for identifying folks with gender identity that is not cisgender and how we can be better. Since I know I will probably run out of time, I want to make sure that I shouted out Dr. Kim. She's been a really wonderful, wonderful mentor, and I did not get her permission to use her photo, hence the stock image. Similarly, Kylie Keller has been super helpful with all the data and really appreciate the support from the Autism Center. Okay, and for the sake of this presentation, I'm going to be using kind of these terms. So gender diversity, I'm defining as an umbrella term that's capturing a range of gender identities discordant from sex assigned at birth, can be non-binary, can be transgender gender identities, and kind of the wide spectrum. Gender dysphoria is specifically a clinical diagnosis, often based on quote unquote distress related to gender identity and sex assigned at birth discordance. And these are not equivalent terms. So not everybody who falls under the umbrella of gender diversity has gender dysphoria, which is important to note. Okie dokie. So the impetus for this project, I don't think this is a surprise to anybody who kind of works in our field, but, in the last several decades, and especially the last few years, we've been seeing real increasing prevalence of folks who are diagnosed with autism spectrum disorders, and also an increasing number of youth who are identifying as gender diverse. Both of these groups independently have kind of unique risk factors and psychiatric comorbidities. And as we've been seeing kind of these parallel increases, there's been a lot of question as to whether there is a link potentially or some association between folks who are gender diverse and who are also autistic. So Dr. Kim, Kylie, and myself are not the first people to look into this. There's been actually quite a bit of interest in this, especially in the last 5 years or so. So while there is a lot of existing literature in this field, unsurprisingly, there are quite a few issues with most of kind of prior studies. A big one is that a lot of times autism is self-reported or it's conflated with autistic traits. A lot of times also kind of conversely, when we're looking at youth populations, they use data from the child behavior checklist, for example, which asks parents this question: how frequently does your child wish to be the opposite sex? And that is the data that is used to define kind of gender diversity. So understandably, a very indirect marker of a lot of these things. There are also a lot of really good questions about, how we're defining these things and whether some of the quote autistic traits we may see in gender minority populations are better explained by minority stress or kind of other adverse experiences. And there is some thought that neurodivergent folk might conceptualize or express gender differently. They're all interesting questions. And because of all of these kind of gray zones, it's often really hard to define populations in these studies. So partly because of that, there is a very wide prevalence estimate range. Sometimes you see studies where they say 4.8% comorbidity, sometimes all the way up to 26%. Some studies say not at all. So we were hoping to add some clarity to this. We looked at EMR data for youth who were seen at the Autism Center from 2018 to 2022. And again, we were hoping to look at the comorbidity of autism and gender dysphoria. Also hoping to look at kind of a general marker of gender diversity, although full disclosure, one of our limitations, this is difficult to actually define and measure. So in our EMR, they recently added a gender identity field, but there's actually extremely little data that's been collected. So we weren't able to look directly at kind of how people define their gender identity, which is a bummer. And hopefully in the future that will be easier to look at in our system. So kind of with some various other inclusion/exclusion criteria, we ended up with a total of around 3,600 youth with autism diagnoses. And of those 3,600 youth, about 132 also had diagnoses of gender dysphoria. So what did we find? So overall prevalence, we found that 3.6% of youth in our sample had comorbid gender dysphoria diagnoses. No difference with ADHD diagnoses between groups. So our groups being, again, kind of folks who have an autism diagnosis, but no gender dysphoria diagnosis, and folks with autism who do have a gender dysphoria diagnosis. Interestingly, PTSD diagnoses were not frequent enough in either group to analyze, which I think is a very interesting point. And it's certainly like below expectation when we just think of prevalence of PTSD in the general community. Okay, but what else did we see here? So folks that had gender dysphoria diagnoses were significantly more likely to have anxiety and depression than those that did not have gender dysphoria diagnoses. Conversely, those without gender dysphoria diagnoses were much more likely to have a disruptive behavior disorder. Generally speaking, you were much more likely to have a recorded sex assigned at birth of female if you had a gender dysphoria diagnosis, and you were way more likely to be white and less likely to be Black. This group, our autistic folks with gender dysphoria, in our sample were 100% English speaking, and the grand majority of them also used private insurance, not public insurance. So this kind of phenotype, if you will, of kind of sex assigned at birth female and white has been reported before. So it's not totally new information, but what's particularly, I think, striking about the sample we have from our autism center here is that the population was extremely white. So compared, these are kind of hot off the press numbers, by the way, so we didn't have a chance to actually analyze these, but compared to like hospital-wide data, for example, at the Autism Center, there is a significantly higher percentage of folks who are autistic with gender dysphoria who are white than those, again, just at the hospital at large. And this is pretty inconsistent with just the general demographic data from the Autism Center, where you see a much lower overall percentage of folks who are white, and it's much more likely just in general to have a sex assigned at birth recorded as male, and you're more likely to be using public insurance. So one of the other things we looked at was the pronoun data, which was fortunately kind of more available than the gender identity data was. Although the flip side is that that's also a relatively new marker in EPIC. So we don't have a lot of information on it. We were able to pull pronoun information for about, 1 in 5 folks, and about 4 in 5 folks had nothing documented. So kind of unsurprisingly, people who did have gender dysphoria diagnoses were more likely to have pronouns documented. Not 100%, but much more likely. And one of the really interesting things that we found was that regardless of gender dysphoria diagnosis, about 30% of the autistic youth in our sample used trans or non-binary pronouns. So you might be wondering kind of where that information comes from. There are efforts to kind of standardize this across the hospital system. But right now, the way it works, certainly in kind of our clinics, is that this information is usually solicited during scheduling, most likely from a parent. And it can also be part of the registration process. Certainly, individual clinicians can also collect this information, and they should. But I do think there is an active question as to how often that happens and how often clinicians verify that information, like with the patient directly, and whether they're like actually updating that information in Epic. They did pass some legislation, when was this? Almost 2 years ago, where Children's is going to be, well, complying with this legislation, but they're making like a concerted effort to collect this information more systematically. So hopefully, in a couple of years, we will have a better idea of like how accurate some of these things are and have a better sample. But one of the big takeaways from this is that I think a lot of times we are not asking these things. And I can definitely speak for myself. A lot of times I'm not updating the information in the EHR when I need to. So that's just something to think about for your own practice. And I think our findings and kind of prior research too, it really raises the question, like, who are the patients that we're referring and like screening for either gender health concerns or autism, depending on kind of where you are. And if this is a subgroup of folks, like, are we meeting needs adequately? Okay, I'd like to talk about quite a few limitations. Weren't able to look at gender identity data directly, which means we likely did not capture like quite a few people who would identify as gender diverse, but did not have gender dysphoria diagnoses. The Autism Center here is also a tertiary referral center. So there is a question as to whether kind of the patient population we see here is more complex or acute. And kind of just like I was mentioning, there's a lot of inconsistency in how people document information. If anybody does not know how to update Epic, actually Children's has a great little tool here, and I recommend looking at it. Those are my references. That's what I have.
All right. Thank you, Dr. Warner, and the rest of the graduating child and adolescent psychiatry fellows. I think I speak for the audience that we're all really impressed by the level of scholarship and also the forward-looking thinking that went into all of these projects. So congratulations to all of you. I want to give a quick shout out to all the faculty mentors that were involved in the scholarly inquiry project over these past couple of years with our presenters. Of course, all of that is done voluntarily, so thank you all for lending your expertise. We have time for just a couple of questions here. I'll start us off, and then if anybody else has any questions, we can you can open up your mic. So first of all, there's an acknowledgement of how useful that Epic tool is. So I think we're all impressed that that's getting off the ground. Thank you for doing that. I know that was a heavy lift. There's also some interest in Dr. Cartagena Barrera maybe doing a signing of her book at Magnuson. So there are a bunch of comments about that. So my question is for, I think Maya O was post-call, so I'm not sure if she's still on the call with us. Shout out to her for being here post-call. But for Dr. O, if she's here, and Drs. Berger and Fries, I was struck by seeing celiac, lupus, sleep disturbances, as potential etiologies leading to catatonia, and made me think about systemic inflammation and neuroinflammation being an important factor here. I'm curious if you guys have any, if you guys want to comment on any implications for either recognition or treatment along those lines.
I was struck by seeing that in Maya's presentation as well, and comparing it to our data of only 45 people, but none of them had any kind of underlying neuropsychiatric inflammatory condition identified. Not all of them got relevant lumbar puncture, autoantibodies, etc. But none of them were positive for any kind of inflammatory condition.
And we have reviewed our data and the recommendations from those new guidelines with neurology, and they agree with us that we should be looking for those things more often than we are right now.
All right, a lot of big ups, a lot of congratulations and nice comments in the chat here. If anybody else in the audience has a question for our panelists, go ahead and unmute.
So this is Jack. I have again a catatonia question. Did anything come up about the family history? It's interesting whether or not some of these run in families or versus some of them are just like de novo presentations. You would look differently for the causes depending on how that pattern presents.
Oh gosh, I wish we would have like checked that in the chart. We did not. I wish we would have, thought of that. Of course, the genetics might be an interesting predictor.
Well, we happen to have a little project. We could enroll some of those kids as parents. They're probably all one-offs, but it's a severe enough presentation. You predict you could find some significant mutations related to it.
I do think that it is worthwhile as a field to identify quickly, and some people that take years to get better. And are those people catatonia? Is there a genetic component? When does it become a functional disorder? People with epilepsy can have non-epileptic seizures, but what about catatonia? I find that all really interesting.
We just have a minute to go, and I want to also echo my thanks to the fellow group and just comment about how important I think this, frankly, required activity is. It just reflects the, I think, wonderful diversity of our fellow group. If you think about the topics that the fellows chose, they were informed by clinical experiences, by their own background, ethnicity, experiences, prior projects, and looking forward projects. It's just, each year, it's just terrific. And this was another wonderful set of examples. And Doug's comment about forward thinking and opportunities with this, an algorithm for catatonia. Kristen's got one for perinatal conditions. There's a model for anxiety conditions in Latino populations. There are things to do with Christina's work with regard to the ASD population and its relationship to diversity as far as gender issues are concerned. So it's just a terrific example of what they do in our program. I want to thank them all.
I echo your thanks and wanted to just say we don't have grand rounds in July, but we do have a special August grand rounds. Is going to be the postdoctoral fellows presenting their scholarly projects. And I want to echo the thanks to our fellows for the excellent scholarly work they're doing.
Thank you, everyone. And just a reminder, faculty meeting is now.